This is Dr. David Rawson, founder and president of the Canadian Academy of Clinical Sleep Disorders. Welcome you back to our fall series 2021. We hope you had a great summer, time to relax, spend some time with friends, suffer the heat of Ontario, and you're back in the office slugging away like we always do. To get us started tonight, I want to introduce two people who are going to speak on a subject near and dear to my heart. As you know, I formed this academy 7 years ago for the sole purpose of keeping dentists safe and healthy and trying to bridge across to our medical people to build the collaboration that's so important for us to practice dental sleep medicine. And tonight we actually have a dentist and a physician, a sleep physician, speaking on interprofessional collaboration, the thing I've been trying for us all to do for quite some time. Dr. Pudjo and Dr. Sanjive Jain will be speaking in a minute or two. And I just wanted to quickly highlight parts of their bio. It's on our website, it's on your announcements, but sometimes we're too busy to do that. So Dr. Pudjo graduated from the Faculty of Dentistry. I'm going to kill this name, but it's Trisakti University, Jakarta in Indonesia in 1988. She became licensed for Canada in 1997. She has a family and general practice focusing on restorative, TMJ, sleep and airways centered dentistry, and she's a certified provider of the Vivo system, and you'll learn more about that in the coming weeks. Her colleague and medical partner, Dr. Sanjive Jain, is a family physician with a long-standing practice in Oshawa, Ontario. He has been privileged to hold various senior leadership positions at the regional hospital as well as the Ontario Medical Association. Dr. Jain works full-time with a focused practice in sleep medicine disorders. He's particularly proud of creating a virtual platform to facilitate, wait for it, to facilitate interprovincial collaboration between airway-centric dentistry and sleep disorders medicine with a goal to improve and optimize patient care. What a concept. Dr. Jain is also honored to be an instructor and lecturer at the Faculty of Dentistry, University of Toronto, the other dental school in Ontario. Welcome to you two folks.
It's my honor to be invited by your group. I attended a few of your webinars last year, and I enjoyed participating in them as well. I'm honored to be invited and to be presenting today with a colleague that I've been working with for close to 10 years now. We met at York Region Sleep Disorders, and from the moment we met, we knew that we would be working closely together, not just sharing patients, but now there's a friendship that is formed. In any case, the topic today is about interprofessional collaboration and bridging the gap. There is a need to collaborate for us between the professions. Since we've graduated from our medical and dental schools, we basically work in our own silos, and often that's to the detriment of our patients. I'll go to the next slide. We have the same patients as you. Physicians and dentists see the same population. Interestingly, they present quite differently to dentists than they do to physicians. Dentists tend to see issues with bruxism, receding gums, fractured teeth, abfractions, and failed dental work. Now I took Ria's voice when she was supposed to say that. And years later, patients that suffer from sleep disorder breathing tend to suffer from medical consequences like refractory hypertension, arrhythmias, PVCs, atrial fibrillation, increased incidence of stroke and diabetes, mood disorders, and so on. Just to back up on the presentation, when our patients are being seen by dentists or by physicians, they do present quite differently, but they are the same patients. The patients often have to navigate the healthcare system on their own. So what I want to stress today is that we don't have a different set of patients for physicians and a different set for for dentists. They're the same patients. And often there's an overlap in the conditions that you're treating and that we're treating, and we're treating them blindly, and without collaboration, we're really not achieving optimal patient care.
So this is one of the examples of the conditions the patients show us. Jaw dysfunction and pain, tinnitus, earache, headaches, craniofacial pain, neck pain, like Dr. Jain said. They go to different doctors complaining of the same thing, but as the doctors, we see it from a different point of view. So from the clinical assessment, I think this is going to be a little bit long, that I have to go through what we actually look at as an airway-centered dentist. We start with taking the about 8 pages of intake forms, the medical history, and their sleep questionnaires all in there. And in the clinical assessment, we start with the vital signs. We all know blood pressure and oxygen saturation, weight, height, BMI, the neck size, and then we go through extraoral, including forward head posture, skeletal impressions, pain in the facial, in the jaw area, not really the TMJ, but in the jaw pain, thyroid, lymph nodes, skin lesions, scalp lesions, ear, tinnitus. Is it plaque? Nose? Is there any history of intervention, medical or for medical reason or aesthetic reason? Mouth breathing, hypertrophic masseter, and we go down to TMJ. This include the popping, the crepitus, the cracking, all that. In the muscle of mastication, this is the best part for the patient actually, because we actually give them a short massage. We just palpate the muscle, and then they will tell us if there is mild discomfort, awareness, or pain, things like that. I don't have to tell you all the muscle of mastications, because I think we're supposed to memorize all that, right? And then when we get to the airway section, we look at the nasal passages, tongue tight, tongue level, scallop, malampati, classification, tonsils, uvula, soft palate, gag, reflex, underdeveloped upper and lower. And this part of the airway assessment is actually what we always include in our referral form to Dr. Jain, because especially now in the pandemic, Dr. Jain cannot really see what they look like in the clinical setting. So when we put all that information, it makes a huge difference in, I guess, in just giving the clinical diagnosis. Is that right, Dr. Jain?
Yes. So, I tend to see, certainly during the pandemic, I tend to see individuals virtually, either by video conference or by phone call. So it's a perfect partnership in that the person who's the expert in the physical and structural exam, the dentist, has done the exam and has forwarded those results to me. So it's not necessary for me to look in the oral cavity. You can see by the comprehensive examination that Dr. Pudjo has done here that identifying structural issues gives her a greater idea of who's susceptible for obstructive sleep apnea. When the biggest challenge I find in the dentists that I work with from beginning to end is they need to refocus from teeth and gums and zone out, so that they are now looking at the airway and then looking at regional effects of airway compromise, like TMJ dysfunction, craniofacial pain, head and neck pain, forward head posture, et cetera, et cetera. in my practice, in my family practice, I used to see individuals who had refractory hypertension, who had atrial fibrillation. So our patients present quite differently, and naturally, the dentist sees the patient when they're early young adults, and I tend to see them in my family practice when they're approaching middle age. But the underlying issue is the same, and if it can be identified early by structural analysis, and at least there's an awareness that maybe these patients should be screened for sleep apnea, it helps the patient avoid long-term medical consequences.
And that's the reason why a part of our clinical assessment, besides the dental part of it, the oral part of it, intraoral cranial nerve, occlusion function, I think we all know that, the anterior guidance and working and non-working interferences. Periodontal assessment includes the whole period charting, including mobility. The dental part of it is from the cavities into breaking, into you name it. I think we also have a long list. Now the sleep assessment is quite a big part of the intake form. We combine a few questionnaires into our own intake forms, because in the beginning, I've got the stop bang and the Epworth and the Berlin, and it was just a lot of the questions are repetition. So we make our own, and it's a big part of the intake forms. The caudal test and the swallowing test, that is also just a part of our clinical assessment, just to see how much improvement they get when they do the spreading of the nostrils. History of the speech trouble. Now, after all this, it is not unusual that we will refer the patient to an oral radiologist for a CBCT of their head, neck, and airway. And for sure, as soon as I see just the slightest risk of undiagnosed sleep disorder breathing, they go for sleep study. Another additional test that Dr. Jain and I were talking about on Monday, Doctor? Yes. Is we should even step it up with a referral for a hearing test. And on top of all this clinical assessment, we also do photos, intraoral, face, and full body, without us telling them how to stand and how to pose, because we want to see them at their most natural position. That's how we see things. A lot of things we can see, because we cannot stare at the patient when they're in the office. So when we have all the photos, it's very, very nice, very beautiful to just be able to see what we miss when they're in the office.
So Brianna, maybe we can go to a couple of the cases, or do you want to talk about barriers first?
We can do this.
Okay. So not every dentist is going to do the comprehensive exam and be as airway focused as Dr. Pudjo, but almost every dentist is going to see issues like bruxism, receding gums, fractured teeth, failed dental work, abfractions, and those should be a yellow flag, if not a red flag, to at least screen for obstructive sleep apnea. I believe now the American Dental Association has a guideline that even before you make a bruxism appliance, someone should be screened for obstructive sleep apnea, because that appliance may make undetected, undiagnosed underlying sleep apnea worse, placing the patient at a higher risk. Certainly, there are many barriers to collaborating. We're not trained to work with another profession. Generally, the buck stops with us. The buck stops with the physician when you're in the office, or with the dentist when you're in the chair. And for us to be collaborating with another profession is certainly new ground. Most of us are not willing to change our usual way of practice, But those that are willing to change from a profession-oriented to a patient-centric practice will be rewarded with better patient outcomes. The components necessary for successful collaboration include understanding the roles and responsibilities of the various professions and a basic understanding of the anatomy and physiology and terms, medical terms, dental terms that are used by each profession. I know that before I started to work with dentists in sleep medicine, I had no idea what a palatal tori was. I didn't know anything about bite misalignment or why I should worry about that. And I would get a referral from Dr. Pudjo and she would say, well, palatal tori and tongue tie, please rule out sleep apnea. And I said, well, wait a minute, I don't understand what your concern is. Is the patient snoring? You have been witness breathing pauses and so on. So my understanding of what Ria is seeing helps me understand what she's concerned about. Communication is key. All of us practice very differently. Physicians see patients differently, consult with them, follow up differently, and we chart our progress notes quite differently than a dentist. There are certain requirements that I have when I get a referral from a dentist or a physician. One of the reasons that I can see patients from dentists is I'm a family physician that practices sleep medicine. So I don't really bill a consult, but I end up having an educational discussion about obstructive sleep apnea and why it's relevant in their oral health and why it's relevant in preventing future medical complications. Sharing of medical and dental information. So, I send letters to Dr. Pudjo and she sends me notes as well on progress, on follow-up notes, on sleep studies, on issues that patients are having or any calls that I got. That sort of collaboration and communication ends up leading to much better patient care. And the last part I'm going to leave to Dr. Pudjo. This is critical, but before we get to that, there's one other area that's really allowed us recently to collaborate even better. And that is the ability for a dentist to do home sleep testing as a screening tool prior to them coming in for an in-lab test. Sometimes patients, certainly during a pandemic, are not interested in going into a sleep lab. Further, prior to the pandemic, there was a 3 to 4 month waiting list to get in for consultation, having the sleep lab do the test, getting a report back from me. And if there was dental work that was being considered, either vivos or mandibular investment, the momentum in treating the patient was lost if 6 months went by between the time that structurally Dr. Pudjo identified an issue and by the time she got the patient back when I was done with the investigation. So having the ability to do a reliable, validated home sleep test has really made our collaboration far better. Her office has probably the best example that I know of team member engagement and empowerment. So I need Ria to talk about that.
So let's look at our first case study on how the two of us are actually taking care of this patient. 41-year-old male, and I saw the patient for a comprehensive exam in 2019. I don't have to go through the whole clinical examination and assessment because we will be here until tomorrow morning. I will just do the points of the reason why I feel that the patient has some risk of either having or developing sleep disorder breathing. Snoring, he's got Mallampati classification 4, which is restricted. He suffered from headaches, and the main key that I said, I have some question about sleep disorder breathing is the Epworth score. It's 17. That's a little bit too high. So I send the patient to Dr. Jain.
We did an in-lab test in March of 2020, and he was diagnosed with REM-dependent or REM-predominant obstructive sleep apnea with an overall apnea-hypopnea index of 8.9 events per hour and severe in REM at 36.2 events per hour. Interestingly, males and females tend to present differently when they have REM-dependent sleep apnea, and even when you have mild REM-related sleep apnea in women, they present with severe daytime fatigue. The usual treatment for REM-dependent obstructive sleep apnea was recommended, which was CPAP, but the patient declined this. So I sent the patient back to Dr. Pudjo, and he saw her after some months because his sleepiness and fatigue got worse, and I'll let Dr. Pudjo describe what happened next.
I think what happened next is actually office is closed because of pandemic. It's March 2020. So I guess that's the main reason why we didn't see him until later on. So and his wife is a part of our dental team who has seen the benefits of oral appliance therapy. And because the sleepiness and the fatigue has gotten worse over time, then we inserted Vivo's appliance in June 2021 with an affidavit from the patient that he declined CPAP machine, even though we recommend it very much. And sure enough, after he started wearing the appliance, he only felt better about 2 nights. And then after that, things kind of went downhill. He started snoring really bad that the wife couldn't sleep and he couldn't sleep. He's tired and the wife is tired, and we need the wife to be able to, of course, be a part of our team. And we ended up having the patient tested, evaluated using the Matrix Plus, and lo and behold, the result is that he is a non-responder to oral appliance therapy. So I spoke with the patient and I said to him, seriously, I think we need to give either an APAP or a CPAP a try. So I refer him back to Dr. Jain.
And this time he was a little bit more open to the idea of PAP therapy, and we chose auto-titrating CPAP because of the REM-dependent nature of his condition. So we wanted a lower pressure when he wasn't in REM, and the machine would ramp up when he is in REM. He felt somewhat better, but not completely better. To me, he told me he was somewhat better, and I sent him back to Dr. Pudjo because he also had other issues, dental issues, TMJ, and so on. So I'll let Dr. Pudjo say that she followed up with the patient, and he told her something different than what he told me, which happens all the time. To me, he tells me he's feeling better, and thank you very much. And he went back to Dr. Pudjo and said, go ahead, Ria.
I think the sweet thing about this case is because the wife is one of the dental team. She's my chairside assistant. So every morning I could actually ask her, how is it going? How does he feel? And then I would also ask the patient myself, how was your sleep last night? Do you feel rested and all that? So the first few days, he was so excited. He slept. He managed to keep the APAP machine the whole night on the first night, and then he woke up feeling so good. So we were so happy. A lot of hope. But it didn't take a week before his daytime sleepiness came back. And I didn't know what to do. So I asked Dr. Jain, what are we supposed to do? Patient is only feeling better for less than a week. And Dr. Jain said, well, send him back to me. So here you go. Patient is back to see Dr. Jain.
So although originally he declined doing a second sleep study for titration because he said you have a machine that automatically adjusts to whatever I need anyway, I don't want to spend another night in the lab. He did agree to do a titration study. We found an optimal pressure for supine REM sleep. And since that time, he's done much better at that fixed pressure, which is a little unusual for REM-related sleep apnea, but he has done better.
And so happy patient, happy wife, happy dental team, and happy me. We're good.
Okay. Maybe,
so
yeah,
back to you, Dr. Jain. Yes.
This is what I find happens mostly even just in medicine. But when we add modern medicine that includes all sorts of allied health professionals with their own expertise, the patient is often left to navigate the healthcare system on their own. They need to become their own advocate. It's hard enough just to navigate the OHIP system, but to figure out, do I need to see a physician about this issue? I'm having tinnitus, I'm having ringing in my ear, I'm having head and neck pain. Should I see my doctor or should I see my dentist? Should I see my physiotherapist or do I see my chiropractor? Maybe I need to go see a naturopath. No, maybe I'll just go for a massage. Oh, the ringing in the ear, I'll go and see my ear, nose, and throat surgeon. We'll have a hearing test to make sure that I don't have hearing loss. But after that, is there really a lot that an ENT can offer? If there's no hearing loss, we're right back to, I still have ringing in my ears. It's left up to the patient to navigate this system. And you're gonna hear this from a physician, but in sleep disordered breathing that ties all this together, the perfect coordinator of care, which in medicine was a family physician, in sleep disordered breathing, I believe that the ideal person is the dentist. And we will talk about a case that illustrates this kind of navigation.
So let's look at another case study. This time, patient is a female, 20 years old, with the chief concern of tinnitus. She went first to her family physician, who referred her to an ENT specialist. And after everything is being evaluated, there is no issues in the actual ears. Patient is referred to me. And of course, head and neck exam, comprehensive exam is being done. And first thing I notice is there is quite a risk of sleep disorder breathing because she's grinding so much and she has quite a large night guard. She had a new one only 4 months before the existing one, and she killed the one before that in 6 months. So she grinds so much. She is a case with the 4 premolar extraction. So you can imagine that the arch is actually quite underdeveloped, and the tongue is full, blocking the airway. Couldn't see her throat, anything, because it just totally blocked with her tongue. And I was thinking, how is she actually doing in terms of the sleep disorder breathing if the mouth is already too small for her tongue and she's got this big oral appliance for grinding? So I refer her back to the ENT specialist who's also a sleep doctor for a sleep study. And the patient declined in-lab sleep study because of pandemic, and the patient is referred back to us for home sleep test. So we did the home sleep test. We used sleep image for her, and we actually did 2 nights sleep study, one with the oral appliance and one without the oral appliance. And we send the patient back. No, we refer the patient to Dr. Jain.
So my role was to interpret the diagnostic sleep study, both with the oral appliance and without. And the sleep image system that Dr. Pudjo is referring to is cloud-based. The patient wears basically a ring on their index finger or their thumb. The test is done in their home overnight. The test has been validated against PSG. And I looked at both studies, both with the oral appliance and without the oral appliance. Much as the American Dental Association guidelines recommend, her condition was much worse with the oral appliance in place. So she had mild sleep apnea that was slightly worse in REM sleep without the oral appliance, and it was much worse with the oral appliance. And I made my recommendations for treatment, including mandibular advancement, and I sent the patient back to Dr. Pudjo.
So I got the reports, and I, of course, forward the report to the referred doctor. And somewhere along the line there, as a part of the head and neck exam, of course, we send her to oral radiologist for the CBCT. Got the report back, and this is the time when after I gather all of the information, I review all the reports, all the findings with the patient and also the parents. Now, and also we talk about treatment recommendations. So I think let me just talk about the reason why I like to share my thinking process here just for a few minutes. Why tinnitus? As soon as it is cleared by the DND specialist that everything is okay in the ear, then the first thing we have to think about is how to decompress the joint. Maybe there is some remodeling in the joint. Maybe there is too much pressure. Why is she grinding? And because we know her result is actually worse with the oral appliance, then I could actually talk to the patient about treatment recommendation that, yes, she actually needs a daytime and nighttime oral appliance to decompress the joint. But at the same time, at night, she's not a good candidate. She's not good with wearing the regular night guard because she developed a mild sleep apnea with the oral appliance. And when we look at the CBCT, her right condyle is 40% gone because she just destroyed so much. And the way I spoke to the parents and to herself as well, I said, if you already have this kind of condyle at 20 years old, how are you going to be when you are 30 years old, 40 years old? Okay, you have tinnitus, but tinnitus is actually a result of the remodeled TMJ. So this is the reason why our workflow is a lot of referring back and forth, because I'm not comfortable giving any treatment recommendation before I see all the reports and all the findings in front of me. And I guess this is what we call patient-centered care. Would you like to add to that last slide, Dr. Jain?
No, I think that in addition to sending the patient back to you for treatment with an oral appliance, generally I follow up with patients 3 to 6 months after to see how they're doing in case their sleep disordered breathing persists and they need further interventions. So Another benefit of us collaborating is me understanding your language, me understanding your approach to patient care. And when they hear the same message from me that they need to protect their temporomandibular joint, and that becomes almost primary when it's mild sleep apnea, and protecting that TMJ, not with CPAP, but with an oral appliance, leads to much better patient care. When they hear that from a physician who's not selling them an oral appliance, it reinforces a message. And the fact that I want to continue to see them after they've seen you, the patient does feel like it is patient-centric care, and that we genuinely care about what's happening with them. It isn't a very long appointment with me subsequently in follow-up, and it doesn't take much of my time, but it is rewarding to hear when they've had great results with oral appliance therapy. And it's also rewarding when they haven't had good results and we can intervene and make them better. So that's become my model of care, and we've been doing this together for at least a decade, I believe, since I started working with you. But I really do want to hear, because time's getting on, about the team member engagement and empowerment, which was the next slide. And because you've done such a wonderful job, I've attended as part of your team some of the patient webinars that you put on, and it's hard for me to know when the qualifications of the person speaking, because all members of your team are well versed in the full care plan, and I have never come across that before. I must tell you that.
Thank you. And guess what? Most of them are here with us, with me, not here in the office, but attending all this. So I guess I should start with, just look at the word team. Why I don't call them my staff? They are my team. They are beside me. And I may be the leader of the team, but I'm not above them. Everybody is stay in one level. Everybody has a job description, but we are together. We are a group of people come together to achieve a common goal. I think that's the definition of a team. So team member engagement and empowerment is a process. We didn't get here overnight. It takes us years. It takes us bad days, good days, celebrations, continuing education together, cruises together. 1 week on the boat, did wonders. It's wonderful. Unfortunately, due to pandemic, we couldn't go last February. It would have been our third trip together. It just, the bonding and the communication that we work every day on how to finesse, respect each other. So all that, I think the foundation for the team, being in the team together. So I really believe that we need to engage the team in all we do, the leaders do. Educate, sharing what we learn, recognizing the strength of each member, and also not just the strength, but also the challenges. Empower them. As the team members they are the ambassadors of the office. They're the one who's doing the communication with the patients, with other offices. We just need to keep encouraging them to do more and to learn more. And the big key word for me is trust. I trust them. And yes, we just have to keep reviewing on, what needs to be done. Is this the right thing to do? Is this the correct way to do? Everything is correct. We just have to be in the same platform, in the same way of communication, so that we can really do this together. So let's talk about the ambassadors of the office. A lot of times, even after we see a patient and I explain the finding, explain the procedure, treatment plan, answering the questions, and then before I leave the room, I said, so is there anything else you need to ask me? And they say, no, I'm good, everything is clear. And as soon as I just one step away from the office, they turn into the assistant who's in the room with me, and they started asking questions. And after that, they would go through the reception area, and then they will ask Courtney, our office managers, in the front. Sometimes they leave and then they send an email with more questions. And I trust that they get very, very similar answers to their questions to all of us, the team members. So every staff member understand and on board. The hygienists, they're a big part of the team as well. They can see and recognize the signs and start asking questions and educating the patients along the way. So many ideas come into my mind on how we as the leader of the team can do to engage and empower team members. But for tonight, I think I will leave you all wondering on how you will do it in your office, with your team.
If I can interject, Ria. So one of the benefits of working with an office that has an empowered team, both for the patient and for the referring physician, I don't need to phone and get you away from whatever you're doing with the patient on the dental chair. I can ask one of your team members the status of a patient. Similarly, if you enter sleep dentistry, you will get kind of calls that you don't get in a usual dental office. And many of those can be handled by team members other than the dentist. And there are many benefits to team member empowerment and engagement, but I thought we would include this as part of the interprofessional collaboration, because the interprofessional is not just between dentist and doctor, it's also between us and our other team members within our own office.
Yeah, and I'm sure all of us attending right now will agree with me that having a great team is everyone's dream. And I feel so blessed and honored to have my dream team here with me in this webinar. They're all here without me asking them to be here. So we're talking about dream team here, right? Can you see that? So thank you for being here and in the office. Courtney, Mahin, Vera, Marcella, Diana, Lillian, Gabby, Lisa, Dr. Eng, Dr. Patchman, and last but not least, Dr. Jain. You're not just the sleep doctor who we refer to patients to. You are a part of our dream team.
But Dr. Pudjo, I wanted to remind you that I wanted to be included in one of the vacations, and you immediately told me I only pay for my team members, not for physicians. Let's go to the last slide, and then maybe we can field some questions. There are many benefits to collaboration. Certainly dentists get to participate in assisting and decreasing the incidence of coronary artery disease, diabetes, stroke, and atrial fibrillation, things that would happen well down the road. And physicians are certainly able to participate in the management of craniofacial pain, temporomandibular disorders, and other regional effects. I can tell you as a practicing family physician that these are issues that are very difficult to manage within the OHIP system. No one knows where to send patients, let alone treat them, and treat them well. So, and the idea that I would be involved in improving oral health and decreasing dental treatment failures is rewarding for me. We know that dental health often leads to great systemic health, and there are many studies that have shown that. If you wanted to reach out to either one of us, you have our emails here. Certainly it isn't just me. Now, Dr. Pudjo says that she refers to Dr. Jain, but I have a team of sleep physicians at Sleep Care Hub that work with me that are of like mindset. But my existing relationships that I've fostered over the years, I intend to maintain my personal relationship with Dr. Pudjo, who often will send me a message on WhatsApp in the middle of the day, but it's quite all right because it's usually important and it usually doesn't take much time. So we're happy to help. I hear from other dentists, I can't find a physician to collaborate with. Where do you find them? We have a team of physicians that can work with, and certainly I have patients from other from other physicians that I end up referring to Dr. Pudjo or other dentists that I work with for management of TMJ, and the family physicians or specialists are quite thrilled that someone can take care of these issues, including tinnitus, which is my whole career has been so difficult to manage. And it's only in the last few years that I've connected the dots, and it's been the dentists that have connected the dots for me that really it's not an ear problem, it's a TMJ problem. And if you help the TMJ, you will get rid of the tinnitus. Not in everybody, but in many patients.